I'm Ann Dunkelberg, Associate Director with Center for Public Policy Priorities, and I wanted to mention a couple of things before I delve into these slides just for a minute. And one is that with respect to some of the earlier discussion, and I will definitely follow up with your staff about this, I heard a lot of references earlier in the day to able-bodied adults, and one of the fact sheets that we've provided that we have on our website that I'll go around and talk to people's staff about is one that explains that in fact many Texans with very serious, grave illnesses do not qualify for Medicaid today. You don't get a disability determination because you have an MS diagnosis or a cancer diagnosis or even a schizophrenia diagnosis. Until you can no longer work or you're certified as being within 12 months of death, you can't get SSI. So we have tons of Texans with serious illnesses that are going untreated because they fall into that gap where they don't get the subsidies in the marketplace, but they are not sick enough yet to get Medicaid through SSI. So I wanted to mention that. And then the other thing is just to mention for future reference, and I'll be happy to come around and talk to staff about this as well, that I spent about 8 hours with the HMA report this weekend because that's really what it takes. There's a ton of good information in there, but I noticed at least 3 sort of major methodological questions about it, and one of them speaks to one of the things you've talked about today, which is they referred to the fact that they used the Urban Institute's model for their Medicaid expansion and predictions. However, when I looked at their numbers, they didn't match up with the Urban Institute's. The Urban Institute predicts that the uninsured rate due to new Medicaid enrollment of the newly insured would go down by 1 million to 1.2 million, whereas this estimate is something like 668,000. When I checked with Urban, they said that their model assumes take-up rates between 70 and 88% based on the actual experience of other states, and that they had advised HMA of that, but that HMA nevertheless chose to use a 60% take-up rate. There are some other methodological issues, but I think that's one of the biggest ones that's worth noting. So there are some number issues that I won't drone on about right now, but I would love to follow up with your offices about them. And the other 2 are not minor either. The rest of my handout is really only about a very simple analysis that we did using HHSC data from the waiver. All it does is show, using HHSC waiver year 4 data, which was the last year of complete data we had, it showed what a 25% reduction in DSRIP would amount to and what a 50% reduction in UC would amount to. Even based on the HMA, everything I know still confirms that if CMS follows the rules that they are talking about, a 50% reduction is still very much likely in UC. There's nothing I found in the HMA report that really changes that picture for me, although there's, as I said, lots of good information in there. So I just wanted to make you aware that this report that we put out in July does show what a 25% DSRIP reduction and a 50% UC reduction looks like by county, by RHP, as well as by hospital. And so this is just a handy resource to understand sort of the magnitude of the fiscal impact that some of the folks that you're hearing from in your testimony are looking at. And I know I need to wrap up, but I do want to point out that on slide, well, they're not numbered. What should be slide 5, there is a chart that has some of the major counties from districts of members in this committee showing what the 1-year 2018 reduction would be with the projected reductions in the waiver that we're talking about. And I've appended 2 other slides, and then I promise I'll wrap up, which I wanted to make sure you're aware of. We have a feeling that there are many people here at the Capitol who literally do not understand that this is the situation we have in Texas. That because Texans under 100% of poverty can't get coverage in the marketplace with subsidies, their next door neighbors who make $1,000 a year more than them, the parents can get coverage for $40 a month, but the parents in the lower income family cannot. I've also gone through, I think a lot of us don't understand how many people are really working at those incomes. We have somewhere in the neighborhood of 45 state of Texas classified jobs that if you're supporting 2 other people or 3 other people at the starting wage, you'd be in poverty. Now, our state employees have some good coverage. They're not the people I'm concerned about, but it's important to understand that there are tons, especially of young families, young working families, that really are, headed by a full-time worker, and they are still under the poverty level. So I've gone on a little too long, and I thank you for your time and happy to answer any questions.
I'm just saying, Cover Texas Now is on every page here, and if you want to cover Texas, you really can't do it just through Medicaid expansion, as I've discussed and has been discussed in this committee. Why aren't y'all arguing for flexibility at the federal level so that Texas can fashion a program that covers everybody, that has co-pays and personal responsibility and a benefit design package that's changes based upon the need versus a young healthy adult that needs catastrophic coverage versus that child that was there that was a medically fragile child, instead of a one-size-fits-all Medicaid program that costs too much, that's inefficient, and is really suboptimal for population-based coverage.
Well, I think there's one area we do agree with you. We do think that Texas can and should pursue a coverage plan that includes co-payments. It uses a commercial benchmark plan and can even have things like medical savings account and a premium-like structure, as Indiana and other states have done. So we feel like there is an option there. We have yet to have anyone who argues
Indiana
for flexibility.
Plan has to utilize Medicaid enrollment.
I'm sorry?
The Indiana plan has to use eligibility requirements as per Medicaid, as does the benefit design has to be consistent with the current Medicaid program.
Actually, you can use a commercial benchmark for this expansion population, and that has actually been in law for a while. I think it's really widely misunderstood. So even Indiana, now that does not mean there is no accountability or no minimum standard. So I think that sometimes that's in the eye of the beholder. For some people, if there are any floors, any minimum standards, then we don't have enough flexibility. And if that is your standard, then you're right, there is accountability that the federal government demands, that you have to meet minimum standards. But those are the same minimum standards that are available in the marketplace. So the same ones that Arkansas people are getting when they buy coverage through the marketplace. They have to have the 10 essential health benefits and those sort of things. Mental health parity is part of the law for both Medicaid and for the marketplace. But we see those things as steps in the right direction. So I think that there's a lot of room for agreement. But again, whenever people start talking about flexibility in a way that's not real specific, we want to know what it is you want to cut back on. And that's a lot of what we're here to talk about.